because it's only good morning in Central Time and West Coast time. Well, what about those on the East Coast, right? So we have to say good afternoon to them. And I want to thank everybody for being online today and being here in person. So first off, I want to let you know my name is Stuart Schlossman. I'm president and founder of MS Views and News. And we're partnering today with Advanced Neuroscience Institute here in Franklin, Tennessee, who is sponsoring today's program called Innovation in MS Care. Okay, and we have sent out many of the topics on social media and via our database. So for those that are on here, I'm sure that you're very well aware of the topics that we will be doing. So our first speaker today is Dr. Samuel Hunter, and I just want to give a little biography of Dr. Hunter. And I know I have glasses here. I should be wearing them, right? So Dr. Hunter cares for over 1,000 people with MS actively, many with severe or complicated disease. He performs consulting on drug development and research. He draws a broad background in clinical pharmacology and has ongoing interests in neuro-ophthalmology, neuroimaging, brain repair, and electrophysiology of demyelinating disease. He aims to float all the boats in supporting neurologic education and research and to attract research dollars to the Middle Tennessee region for his patients. Dr. Hunter serves as a principal investigator on many neurological trials for both industry partners, for the NIH affiliated trials, and for investigator-initiated protocols. Dr. Hunter has performed basic laboratory research with stem cells in demyelinating disease, numerous national and international research trials for multiple sclerosis, as well as his own trials on his own designs, and continues to be active in clinical trials. He works with several nurse practitioners as part of a care team for complex neurological case management. This could go on and on and on. So let's just welcome Dr. Hunter.
Thank you.
Thank you.
Thank you. Appreciate it. Well, good morning and welcome. And I'm very pleased to be working with Stuart Schlossman and two of my other colleagues that you'll meet in a little bit. And we're going to do some presentations about innovations in MS care and treatment. It's very hard now to do an MS program without talking about what's coming soon, and and what's already here that you may not have heard about or understand our perspective on MS. So we'll get started here, and we have a number of questions that have been sent in that we'll come back to at the end. So there's going to be a presentation from me, from Dr. Hawkwood, and then from Dr. Cantor, and then there'll be a question and answer session that Stuart's going to mediate from the questions that have been sent in online. All right, so NeuroNexus is sponsoring this, and that's the local nonprofit for research and education. Just a reminder, if you participate in research, you're helping us to cure MS. And we have clinical trials. Every one of these doctors has clinical trials. People who participate in clinical trials are heroes that help us all. And so there's a lot of things going on. All the time it's changing. So if you've been in my clinic, you've heard me make wisecracks about MS, and one of them is that it's all in your head, but it's not your imagination. So with that in mind, we're going to proceed to talking about MS and help you understand a little bit more, you and your family, about this illness. So in my presentation, I'm going to go through how we deal with MS and an MS diagnosis, how things are changing in terms of how we care for MS, some of the newer medications, and the future of how we're looking at doing MS care. So one of the things that I strive to help people understand is how they got into this situation. And it's really important both for your well-being and for your family's understanding that they understand a few things and what MS isn't related to. And it's really not a genetic disease. The risk, however, is genetic. And a lot of that genetic risk is a propensity to have low vitamin D levels, which is multiple genes. These genes are good genes. They were for surviving, and they're very common genes in people from Northern Europe. It's mostly not a virus. Although MS acts like a virus, It acts like a virus in animals. These diseases in animals are all due to viruses. They're set off by viruses. We can reliably reproduce that. But in people, we know everybody with MS does have a particular virus, and it's called Epstein-Barr. It is a common virus. Most people have it, but every last person with the MS who's ever been seen to have MS has this virus. So we're pretty confident that this virus is a part of the puzzle that results in people getting MS. Once upon a time, people perceived that maybe mercury in their fillings was causing problems. Mercury does not cause your problems. If your teeth are in bad shape, you need to get them dealt with. If your fillings are bad shape, you need to get them dealt with, but you don't have to have your fillings removed to take care of your MS. There's been now for 25 years an urban myth circulating on the internet about aspartame and it causing MS. It absolutely does not cause MS. It is not a big deal for most people. If you're drinking 10 quarts of soda a day, you should stop, but it is not going to hurt you very much. Drink coffee or tea, they're good for you. Fungus does not cause MS, as far as we can tell. You're not being poisoned by fungus in the air or by the mold that is an inevitable part of exposures in life. Fungus isn't good for you to breathe a whole lot of, but it doesn't cause your MS. Some people feel like a particular nutritional problem or gluten sensitivity or other allergies could be the cause of MS. Certainly bad allergies are going to make any inflammatory problem you have worse, and poor nutrition could potentially do that, but these don't by themselves do that. We used to think dogs caused MS, and there was a hypothesis that the MS was really distemper, which is a canine virus, and distemper is very much like MS. And so it wasn't a bad idea, but it just doesn't seem to have borne out. And at one time they thought that you got MS because you had a wild lifestyle. And this also is not true. It has nothing to do with it. But basically you get MS because of bad luck. Now, what does cause MS? The genes are important in terms of reducing risk, but anybody can get MS under a certain set of circumstances. But they are good genes. They are not like the Joker. They are like, a bad hand of gin rummy. You could play it in certain circumstances, it would work fine, but in others it doesn't. They tend to keep the immune system running fast and making lots of cells, these genes, which is very good if you have TB or the plague or parasites, which is what basically until 100 years ago was the state of affairs for humankind, and people were lucky to live to 30. Now we are very healthy, and we still have these immune systems that are really running strong. We know low vitamin D is important. Now, low vitamin D is not rare among people, but low vitamin D increases the risk of getting MS 10 times. And we know it's many of these things that have to do with the likelihood of getting MS also have to do with how severe it is. And so it serves both those roles. We talked about Epstein-Barr. Most people have it. There's no sense in checking yourself for it. You'll have outrageously positive tests to it. That's normal. You don't have mono still. It's not chronic mono. It's not the same thing. And mononucleosis is a marker for MS risk, but most people with MS didn't have mono, and most people with mono don't get MS. So we have become aware from careful studies that obesity, especially in adolescents, is a risk factor for MS. Obesity produces inflammation in your body. It promotes inflammation, and that's probably the mechanism why. The one really exceedingly powerful thing that happens in the environment that really increases the risk and the severity of MS is tobacco smoking. It's not nicotine, it's the air pollution. And air pollution also does this. So if you live in a big city that's dirty, it actually can make you sick. Salty food probably has a role. We're not talking about just salt in food. We're talking about salty food. And high daily salt intakes look like they're associated with more MS activity. But still, your MS is mostly just due to bad luck. All right. So the problem with the bad luck is it doesn't stop once it starts. Most of the problems that are going on, you really don't notice. They're building up over time in ways that you can't perceive. And the same things that we talked about also make it worse. What kind of symptoms do people get? The symptoms they get are both invisible and visible. The invisible symptoms, for the most part, don't indicate the severity, but they are annoying to folks with MS because they can't get other people to understand that they don't feel good. And the number one is fatigue. I interviewed a gentleman yesterday for a series associated with this, and he can barely walk. And he has trouble with his vision, and he had to quit work, and he blames the fatigue for the worst parts of life. And a lot of what people with MS say has to do with this. We'll talk a little more about fatigue. Sensation abnormalities, which can include pain. Mood abnormalities, which have to do with depressive-like symptoms for the most part in MS, are a huge part of why people don't function well. Dizziness, vertigo, the sensation of movement is very common in MS, and it's due to very small disruptions in the brain for the most part, but they're very disturbing and cause a lot of illness. There are a few invisible symptoms which really do indicate the severity. These are thinking and word finding problems because to the people who have MS, they're showing a lot of effort to get things done. This is frustrating them. It's the same thing as trying to function late in the day if you haven't had enough sleep, if you're drugged or you've been sick. Bladder dysfunction, of course, unless somebody has really gross problems with their bladder or bowels, is not noticeable, but it does indicate the severity of the disease. So what we can see easily are things like vision and balance, strength or clumsiness, things that affect how people walk. Tremors. Tremors, again, are really only really important if they're bad enough to interfere with how people's hands work, but they're noticeable many times. Other kinds of coordination problems, and actually problems with speech. And we distinguish in neurology between speech and language. And language and word finding is a completely separate issue than how people produce sounds, which is, technically slurred speech. All right, so you have people who have lots of different problems, but they all have the same illness. It may be different from person to person, what combination, but fatigue is a huge problem for people with MS. Trouble with their concentration and their vision are often very frustrating problems. These probably are among the most common reasons that people have occupational disability with MS. But some people will get coordination problems. Some people have walking problems. These are often signs that the MS is affecting the nervous system in a more severe way. Pain is a very dramatic symptom, but it actually doesn't represent as serious a dysfunction in the nervous system. And spasms are painful as well and can be correlated with really serious problems. And then, of course, people have trouble with their bladder. That is actually something that there is so much to do for now, and a completely different area of specialty care than what neurology usually is. Now, the underlying reason why people get MS is they have aggressive immune cells called lymphocytes that cause MS. We share our immune system with animals going back to sharks, and the immune system is a very basic function, and we have immune elements that are trained genetically, and we have others that are trained by experience. And T and B cell lymphocytes are trained by experience, and these cells are what go awry. They get trained to react to the wrong thing, and then they don't forget. And these aggressive lymphocytes, in this image on the left, that is not a heart, that is a lymph node. It has inputs and outputs, and cells come into it from experiencing things in the skin and from the blood, and then they react with other immune cells, and they get activated, and they head out to get back into the bloodstream. And once they do, they travel around the body looking for areas to cause inflammation that they react with. They go in there, they sense, if they see what they're reacting with, they're going to attack it. And they literally go in and they start dropping grenade-like chemicals onto whatever the cells are that they react with. And this, of course, is very disruptive. It disrupts the connections in the brain. In the last panel there, you see the one nerve cell you have that your mother talked about you getting on. It has an input and it has an output. And it's got connections in between. these connections are fabulously long in most cases, sometimes thousands or a million times as long as the width of the cell. Very delicate, with insulation that lets them function with very modest energy requirements for their size. This is what's damaged in MS. If it's damaged really severely, then it leads to actually the loss of the nerve cell as well. And this kind of damage is in part repairable and in part not repairable. So this is the wanted poster for the guys who are involved in causing this damage. Lymphocytes are the ones that, for the most part, are causing the problem. They are the instigators. You can actually take lymphocytes from one organism, give them to another organism, and cause the disease. We know it's completely sufficient to do so. That's why we call it an immune disease or an autoimmune disease, because you can reproduce it that way. Now, there are other things that started it, but we know that those cells are sufficient. And then they have friends. They have B cell friends. The B cells kind of get involved along the way. They're just part of the hangers-on. The T cells direct it. The T cells assassinate things, but the B cells kind of keep the party going. Some kinds of B cells make antibodies. In certain people, antibodies are very important in the MS process. Those are called plasma cells. Have nothing to do with plasma. So they're just called that. And the T cells really are the hooligan / ninja killers in the nervous system. They get in there, and just a very few of them are responsible for the majority of the damage that occurs. The macrophages are genetically programmed cells that clean up the mess, and they get in there and they can get very excited and they can cause injury themselves. So this is a very complex slide that basically talks to you about what we mean by demyelination. The inflammation in the white matter of the nervous system causes disruption in the insulation, which leads to a very unreliable energy state and ability to transmit signals. Everything we do, every last movement, every word involves this huge orchestra of these movements in very short time frames to make what we do as organisms really happen. And that is what goes wrong. And so signal block of these signals leads to more inappropriate consequences than just it slowing down. It's slowing down, you don't notice. If signal gets there, you don't notice. It's just less reliable, and it blocks, and then it doesn't work. All right, when we boil down to the tiniest levels, and we're talking about a thousandth of a millimeter in size, these axons are there. They have this self-contained energy state where they pump ions around to control the signals, and they're vulnerable to their environment. Certain other signals can really stress them and overload them and lead to actually loss of the nerve cell once they're demyelinated. They're extremely vulnerable. It's kind of like a frayed wire, and if you keep bending it, it will break. All right. So the epitome of real discovery that it happened in the 1980s, when we realized that MS was not a disease of attacks. MS is a disease of constant inflammation in the brain. And this is a loop over a year of an MRI in an untreated MS patient. This was actually done before people had treatment, showing these areas of inflammation blossoming. I always compare it to acne to my patients. It comes and goes. Many of the scars heal up. They leave little marks, or some of the severe ones will leave more obvious marks over time. And it's this damage that's 95% of what really happens in MS, in the part of the brain, in this part of the brain, where you don't notice anything really happening. You notice the input and output pathways. We're going to go to the next slide. Now, this slide is showing over many, many years, over 7 years, what the consequences of that inflammation. And what you see is the brain shrinking, the spaces on the outside of the brain getting bigger, the space on the inside of the brain getting bigger. This is brain evaporating from the damage of inflammation. This is what's stopped by treatment. And if you refuse treatment for MS, you will, in most cases, experience this kind of damage, and this is completely irreversible. You cannot recover this kind of damage in the brain. Many people with MS have this kind of serious loss of function even before we get an MS diagnosis. So let's talk a little bit about how things have changed. So 30 years into this, I'm 30 years into my career with MS. The old ways of looking at this was neurologists used to try to tell people MS isn't such a bad disease, that it's usually benign, that treatment was really optional, that we should just keep life simple and avoid risks, and you should just live with your MS problems. But we've learned that that isn't necessary. You know, we know MS takes away quality of life and sometimes years. There's a 50% difference in terms of death and serious disability in people who are treated quickly and people who aren't treated. We've got enormous amounts of data that treating MS at the first symptom and to continue to treat it is important. The goal is to prevent disability and impairment, and we know that MS is not benign 95% of the time. As far as taking risks, everyone feels you should take risks appropriate to the severity of the disease, and you should try to manage the symptoms. So we have drugs now that work on many parts of the nervous system, and this is an example of one class of drugs that are called S1P modulators. There's about to be 4 of these on the market, just like there used to be interferon beta. Many of our drugs do multiple things, and this is just a slide illustrating what they do to the brain cells, and literally they affect every one of the brain cells in a favorable direction. Not only that, they keep the inflammation out of the brain. So this is a class of drugs that controls MS. It doesn't fix MS, but controlling it in the long term means people feel normal. What we know is this class of medicines, and this is an example where small rodents were harmed in the production of these pictures, because this is an experimental kind of MS we call EAE. And what this is looking at is the tiniest microscopic levels, and these little things that look like scrumpy Christmas trees are the input systems from nerve cells in the gray matter of the brain, which is not what we think of traditionally as being affected by MS. What this gray matter is where all the connections between nerve cells are, and these little tiny bumps are called dendritic spines. And the dendritic spines normally connect all the different nerve cells together. When you get inflammation in the brain, even remote from these areas, and usually remote, all of a sudden the immune cells that are resident in the brain activate, and they eat these connections. They normally maintain them, but when they see inflammation, they start taking things apart. This happens just the same as in a concussion and in Alzheimer's disease. People lose these connections. In the middle picture, you can see how these are down about 50% in that area. But if these animals are treated with medicines that suppress that inflammatory response in the nervous system, you see a near normal amount of these connections. This is why treatment is so important. Even treatments that don't reverse the underlying immune defects are important, because they can control the dysfunction in the nervous system that people complain most about. All right, so we've got all these things that are stressing out axons, both acutely when they're inflamed and chronically because they aren't able to be repaired well, and they have an energy state that's really not different from poor blood flow. It's not poor blood flow, it's due to inflammation. We've got new approaches to MS. We try to monitor people to identify who is having trouble with their walking, with their limbs, with their cognition, and their vision. You'll hear an additional talk about vision today. And then we can control spasticity. And the most successful recent advance has been higher dose of toxin injections, which are like Botox, but it's a different product, that are enough to control large muscles, which we never were able to control before, and tailor it to allow people to have their legs unbound and be able to move now. So you can measure yourself. There's ways to do this online. There are online functions. Your doctor can do this in the office. There are different systems. Speed and processing are the things. Memory efficiency is also affected with MS. But one of the simple things to do is measure how far you can walk. And we recommend you use the 500-meter walk, and you measure how long that takes. And we also measure the speed on a short walk, which is a 25-foot timed walk. Everybody has a stopwatch on their phone and can do this. There's a way to measure your hands with a 9-hole peg test. I have a colleague who's promoted patients doing this themselves and has videos on YouTube on how to do it. You can also keep track of your tremor just by videotaping it. That's an easy way to do it. I also have people draw spirals to keep track of their tremor. There's a series of diagrams called the patient-derived disability steps, where you can put yourself on a 9-point scale as to how bad your MS is, and then you can figure out where you fall on the bell curve of MS. So we look at all these functions like cognition. There's a decoding task that we do in the office called SDMT. We have one called low contrast visual acuity. We have the 9-hole peg test, which is just a time dexterity test, and we have ambulation. And all these tests have proved useful in research, but they're also being used to follow people over time. So everybody with MS can put themselves on this scale. You can just read the description. You can say, am I 0, a 1, a 2, a 3, a 4, or so forth. The higher disability people, the people who are barely walking or have to use gait aids, are there. This is just a way to look. And we use legs in MS because they're the most affected generally by disability. And the reason is this longest pathway. It gets beat up on the most by the inflammation. So we have a way to convert the number of years of disease people have to how bad they are on the scale. You know, people who are having walking problems early are much more severe than people who never have any. And so these are the different scales, and this is a great way to quickly sort of get the picture, because some people develop walking problems over 30 years and some people develop them over 3 years. Those are completely different severities of MS. All right. So there's also some new medications and some new twists on some old medications you need to be aware of. And despite our love-hate relationship with the pharma industry, the drug companies have been hard at work, because this is what they do. They find new medicines. Some of these medicines will be clearly improved over old medicines, and some new ways are discovered to look at older medicines and how they're working. One of the old medicines that we have for MS that's kind of new to the United States, but it's actually a medicine for which there were Nobel Prize given in the 1980s, is actually the most effective and cost-effective medicine. And brain repair has been observed in 40% of the people who get this, and it's much more improvement than on any of our other medications. The treatment is complicated. It cleans out the immune system. It restores it with stem cells. It's manageable, but thyroid problems with it are not rare. And there are rare serious problems with blood or kidney disorders. And it's become clear recently that you shouldn't get chiropractic around the time of the treatment, that it increases the risk of having a stroke, which is due to the chiropractic actually. And it also is important to control your blood pressure, because there's bleeding risks from that, including a stroke. We've also learned that during the time when the immune system's weak, it's also important to avoid uncooked milk, meat, or seafood, or poorly handled food. Now, this was always an issue. With people with MS, because they get very sick when they have an infection. But these infections are much more serious in people who have temporarily weakened immune systems from some of our medications. So This is very old data, but this is showing Lemtrada was more effective than Rebif, a very standard first treatment MS medicine. And this is a good group of patients responding to Rebif in this upper black line. This is our disability scale. These are people with fairly mild disability who are treated. But the people who got Lemtrada, which is a much more aggressive treatment, do 2 to 3 times as well. They actually improve in disability better. More of them improve and they stay stable. So we at Advanced Neurosciences, in collaboration with Dr. Kanner, who you'll hear later, have done some studies in people with long-term Lemtrada treatment. And long-term Lemtrada treatment, we're mapping it out here on the scales. And up in the upper left corner, you see the studies that were done to get the drug approved, which are done in people on lower disability. And they largely stay stable or improve a little bit over time. When we treated sicker people who are not walking well, these are in the lower right side, the red stars and the blue stars in the middle of the picture. What we see over many years is these people continue to improve in disability. Not only do they not get worse, the average person gets better. Now, some of the people get worse. 15 or 20% are getting worse. But that means the average here getting so much better means that some people get absolutely dramatic improvements. And this is a disability that traditionally is considered something that many doctors won't even treat because they think it's futile to treat. And this has become clear that people should get treatment. The least of the benefits is people are going to usually stay stable, and the vast majority of people will be stable or improved. All right, I've gone to calling this secondary regressive MS. Everybody's heard about progressive MS. These are people who have progressive MS who actually get better. So I call them regressive MS. And this is just something that you never saw in earlier eras. And now with highly effective treatment, we're able to get this in a significant fraction of people. All right, there's some other really exciting new medicines that are actually, in some cases, even old medicines. And cladribine, or Mavenclad, is an oral version of a very old medicine for modifying the disease. This is a medicine that I've been acquainted with for all of my career. And it is a way to modify the disease in the long term. It is a pill now, a very small dose of a chemotherapy medicine. It's a very elegantly designed chemotherapy medicine. It has very little effects on other tissues in the body other than the immune system. And it's a weight-based treatment. It's very effective. It's just 4 or 5 day treatments over 14 months. And this is just pills. You swallow the pill, and 1 or 2 pills a day depending on your weight. And it's a total of 20 days of treatment that you get over 14 months for 5 years. It does not cause major side effects. Some people will get low blood counts, a rash, or nausea. These are temporary problems. Shingles is a small risk. 75% of patients who take this medicine will not have a relapse for 5 years. It is phenomenal. Now, it's a new medicine. It does have a cancer warning. The cancer risk is actually quite low. It's about 1 in 300. Which is 1/5 of the risk of Gilenya and 1/10 of the risk of Tecfidera, which don't have cancer warnings on them. So our government is unfortunately not very consistent with how they apply these warnings, but they just want people to be informed. It is labeled for pregnancy risks. You need to use contraception for 6 months after you take a course of treatment, and the reason for that is because it would undoubtedly cause trouble with a pregnancy if it was given during a pregnancy. And if someone does conceive between the first and second parts of the treatment, they can delay the pregnancy. They can delay the second year of treatment till after they're done. It actually you can actually breastfeed while taking the medicine as long as you throw the milk away for 10 days after. All right, so there are other medicines that are related to the fingolimod or Gilenya we talked about earlier, a second generation S1P modulator. They don't repair the problem, they control it. Gilenya was the first drug. It's now been approved for children. There are newly identified risks that are infrequent of rare serious infections. There's newly identified risk of seizures, about 2% in adults and about 10% in children. About 10% of MS patients have seizures at some point in their life anyway, but this is exactly what's important for people to understand. There is a risk with these medicines of severe reactivation of the MS when people stop it. So it's very important to plan any change or dropping your therapy with this. There's a drug that was just approved called Mayzent or siponimod that has proven benefit in people with established progressive MS, and it has some complicated metabolism issues and medication interactions. It also was demonstrated to have benefits on mental processing speed. The first such MS medicine where this data is really dramatic and convincing. There are 2 more medicines on the way in this family. One's called ozanimod that'll likely be here early next year. It's a lot like Gilenya, but won't need a first dose. There's another one named ponesimod, which beat Aubagio in a study, actually, and it doesn't have any metabolism issues. One of the interesting things is dealing with the class of drugs that Tecfidera belongs to. Tecfidera is called a methylfumarate. Its problem has always been GI side effects make it difficult. It's a twice-a-day medicine, but there is a new 3rd generation methylfumarate. Tecfidera is actually a 2nd generation. The original one was called Fumiderm. It's approved for psoriasis in Europe. The 2nd generation was Tecfidera, and the trouble with nausea, vomiting, diarrhea, belly pain, and flushing are legendary for some people, just can't take it. Tecfidera has a very small risk of PML and other rare infections. It appears to slowly cull the lymphocyte population that's causing the trouble in MS. The 3rd generation drug, which will likely be available early next year, is called Vumerity or diroximel fumarate. It has virtually no GI distress if taken with food. It has minor flushing issues, none if it's taken with a meal. There's another drug called monomethyl fumarate in testing. So what about spasticity? Botulinum toxin has been available for many years. The doses were low. Dysport, which is the newer branded product that is higher dose, can address many major muscles. I can treat several limbs at once even that are in bad spasticity. I can improve severe leg spasticity and make walking better. In many cases, we're avoiding baclofen pumps because with baclofen pumps, the problem is people often can't walk after they get them. There are new drugs coming that control spasticity better. There's a drug called baclofen ER that we hope will be improved and on the market within the year that gives longer action, more benefit, and less side effects. All right. So where are we going with MS? We want to enhance brain repair. We want to improve walking. The prior drug that enhanced walking was called dalfampridine ER. There's a drug that we have tested that's been published that beats the pants off dalfampridine, and it's in a 3rd stage trial, what we call a phase 3 trial, where it's an old medicine but a new application. It's a amantadine, but it's much higher dose than what you may have received before for fatigue, and it's released in a very gradual way. The FDA approval could be even early in 2021. It's already on the market as a medicine called Gocovri for Parkinson's. You need to have normal kidney function. There's a low risk of confusion with it. So we know repair happens. This is a slice of a brain that's showing repair. These big white zones in the middle of the brain are areas that are not repaired, but you see fainter areas that we call shadow plaques, and you see plaques that are partially repaired. We know this goes on. We know smaller lesions repair better. We know things that are inflamed for a long time don't repair well. These are called black holes. And repair stalls in many of the lesions. It's highly dependent on age. So the targets of repair are these cells that are in the stem cell family called oligodendrocyte progenitors or precursors. And we know that these cells are present in the lesions and they are not able to repair the lesion. But under certain circumstances, this repair can be covered. This is one of the strategies for improving things. First of all, stopping inflammation like we do with Lemtrada or other powerful medicines can do this. The energy status improves, it keeps lesions small, repairs more likely, and we can improve the function of demyelinated axons by improving the health of the axon. There are experimental treatments in development. There's one that may come to market within a couple years that's a very megadose of a vitamin called biotin that's under study to see if it can improve brain function in people who have large amounts of disability. These kinds of repairs are the best way if you can get myelin to repair. If you get myelin to repair, it takes care of a host of problems in the nervous system, and there are experimental trials going on. Several things have been tried. The results so far are not impressive, but it's clear in animals we can make this happen. And even 30 years ago in experiments I worked with, we could make animals go from paralyzed to standing up and waving at you. It was very impressive. Well, I'm going to wind up there and let Stuart introduce the next talk. Thank you very much.